I want to kick off this session, and I'm Donna Lynne. I'm the CEO of Denver Health, which is a very large health system, not just a hospital, but a series of FQHCs, an ambulance system, a public health institute, and a lot of other things. And these are all CEOs, and I'm reminded of a story my son's second grade teacher told me, which was when I came to parent-teacher conference. She said, we went around the room the other day and asked people to identify their parents' professions. And there were lawyers and doctors and firefighters and you name it. And when it came to my son's turn, he said, I don't know what my mother does. I just know she goes to a lot of meetings. So we're going to hear what happens behind the scenes in some of those meetings as we talk to this esteemed group. And I want to identify them because there's, while we cover a great swath of the country, and there certainly are some differences, there are some similarities in this group. So Dr. Brendan Carr from Mount Sinai in New York City. I know there's lots of Mount Sinais. There's Jason Carter, who is the President and Chief Operating Officer of Duke Regional, and Dr. Susan Ehrlich, who is the CEO of Zuckerberg San Francisco General Hospital and Trauma Center. And one of the things that is particularly unique about this group is they're not only CEOs of very large and complex systems, but they are also organizations that rank highly on the Lown Index that you just heard Vikas talk about. And so they have, and as I go through some of the questions, they've balanced a lot of the challenges that hospital CEOs have to think about. How do we, as I said to somebody earlier, no money, no mission, nonprofit systems, safety net systems that are serving a huge swath of people who also have a number of social problems to deal with. They have broad social missions as well as just healthcare missions. So I'm going to ask them a series of questions, and we will, as we've done throughout the day, leave time for your questions as well. But this is a remarkable panel to my left of individuals who not only balance billions of dollars in their revenue streams, but also have to think about what their contribution is to the communities that they serve. So I'm going to start, and I'll start at my far left with Dr. Carr and ask the question, what are the tensions involved with meeting the demands of clinical care, education, and research? So remember, these are academic medical centers as well, which makes it even more complex, while at the same time maximizing affordability and social responsibility.
That's awful.
That was a mouthful.
No. Down.
I think we're going to do this.
Check. Here you go.
There you go.
Just came to light. It's the light. Can you guys hear me?
No.
We'll share.
Yeah.
How about now? Better? Thanks so much. So thanks for the invitation to be here. It means a lot to communicate with you guys about these issues because they are what happens in all those meetings, really balancing the mission of the organization with the business of the organization. Just for those who are not familiar with Mount Sinai, we are indeed an academic medical center, so school medicine, graduate school, nursing school, and a flagship sort of academic hospital. But then we're also a health system, and it's a $14 billion enterprise, 50,000 employees. So it's a big entity. The question you asked is obviously a broad one. Those three missions, sort of are what get us out of bed every day. Most of them do not generate enough revenue to cover themselves. So we have $500 million in NIH research money in our research portfolio, our graduate school, and our School of Medicine. And in addition to that, there's another $500 to $700 million that gets transferred from the health system side to support the research enterprise inside of the school because of lots of reasons I'm happy to talk through, that research doesn't cover its own costs. So, but that's central to our mission. It can add the educational piece of that too, right? Big medical school, graduate school, and nursing school. And it's, it's a gift. It's what brings energy and excitement to my life. I'm an emergency physician, still practicing as CEO, as much as it makes my general counsel want to cry, because they say the moment you get sued, it's on the cover of the New York Times. And I say, yes, but the organization likes to believe that their leader is a doctor that's working in the emergency department in East Harlem. That means something. Anyway, so the educational mission is a critically important mission. And then, the clinical piece, you heard there was I'm wondering if they're still here, the two secretaries of health who in 30 seconds dismissed all the things that make my job hard as they complain and blame the pharmacy benefit managers. They blame the insurance companies and they say that Medicaid doesn't cover costs. I don't know, why would they say that? It doesn't make any sense. Well, it sure seems like it fills up a lot of my day trying to figure out how to, so the clinical mission is enormous, right? And it is the engine that drives the entirety of the organization. We're about a third Medicare, a third commercial, and a third Medicaid across our health system. Our flagship hospital sits at the intersection of one of the richest zip codes in the country and one of the poorest. It's the Upper East Side of Manhattan and Harlem, East Harlem specifically. But our hospitals are spread around the region. With that as backdrop, I'll say that those tensions are financial at the end of the day, but they're very much mission. It is as though it happened yesterday. When I arrived 6 years ago in a different role to Mount Sinai, and I was greeted over and over again with the same story. The book written about the organization was The House of Noble Deeds, which is the way that a president of the hospital described it, because it was a health system or a hospital at the time founded by resourced Jews to take care of marginalized Jews. And then they built a medical school and then a research enterprise, because how do you take great care of folks other than to discover the future of what healthcare delivery and what science and medicine is going to look like? And what was said to me when I arrived was, it's sort of, the marginalized folks are more Black and brown than Jews these days, but it's the same need, it's the same mission, and that's never going to change. So don't screw it up. Welcome to your new job. And the goal here is to fly as close to the flame as you can. Do not let us go bankrupt, but do as much good as possible. And that is the tension. And I'm sure circle back around, but the tension is crippling. And I'm happy to talk about our bond rating being damaged by doing too much good, what that means for the fancy folks on the Upper East Side that contribute hundreds of millions of dollars of philanthropy to us every year to try to service our mission. Anyway, I thought I would start with that because later I'm going to probably blame pharmaceutical companies and insurance companies, and I thought we'd maybe start here.
Thank you, Susan.
How's this? Okay. Well, this has been such a privilege to be here. This is so different than what I do every day at my job. Probably my colleagues on either side will agree with me. And just by way of background, I want to tell you a minute about me and also about our place, because it's really a different kind of organization and we have different pressures. Still have a lot of tensions, but the dynamics are a bit different. So I've been the CEO at Zuckerberg San Francisco General for a decade now. I am a practicing primary care doctor. There aren't many of us out there, doctors who run hospitals and doctors who run hospitals in practice. We can talk about what that's like to balance those responsibilities, because unlike an ED doc, I take care of my patients, over time. I have a panel of a little more than 100 that I take care of, being in clinic a half day a week. One thing, though, is it really makes me aware of the tensions in the organization that everyone is feeling, right? And as a primary care doctor, I get to see what happens when my patients go to the ED, when they're admitted to the hospital, when we make a specialty referral consult. If I refer for an echocardiogram and the next one is available in October, then I know that that's a problem and I can address it. We take care of so our organization is unique. We are a publicly owned and operated organization. We have been on the ground where we sit in the Mission District of San Francisco, which is the primary Latino district in San Francisco, for more than 150 years. We have been in partnership with the University of California, San Francisco for the whole time we've been there. So it's a very unusual relationship, right? It's our single faculty practice, and it's 150 years old. So it's like a very long marriage. And it is a beautiful thing. And I think it's part of what makes us the special place we are. We are the only trauma center of any type in a city of 850,000 people, and we serve the northern part of the county below us, San Mateo. So that is unusual because we are then the only place where people go if they are so unfortunate as to have a traumatic injury. We are the only psychiatric emergency service in town. And we are the safety net, which is really important because our payer mix is the envy of everyone, right? Pretty much all of our revenues, except a tiny fraction, come from Medi-Cal and Medicare. So think about what that's like. And I really want to double down on the issue of social determinants of health, because a lot of the tensions we deal with, in addition to, academics versus care, cost versus quality, all of those things, a lot of the issues are around social determinants, and the costs our patients deal with are not copays or unpaid medical debt. Nobody leaves our hospital with any more than a debt of $4,100. No one. So, but they can't afford their housing. They can't afford to buy food. They can't afford a lot of the things, the basic things they need that all of, us, I believe, take for granted. So that's the tension we're talking about, is how to provide that high quality, high value care in a circumstance like this. Now, I will also say that people love working with us. When you do surveys of physicians who work for UCSF, because all of our physicians do, they rotate with the UCSF main campuses, with the VA, and with us. Where do you think they're happiest? At our place and at the VA. We're the least resourced place, but they're the happiest to be there. And that makes a big difference, right? Why is that? Because we're there, they are there for the mission. The main thing that we're concerned with is how do we take care of the patients who are in front of us? So that's why it's a privilege to be there. It's why people come and work with us and stay, by and large, whether you're a physician or a nurse or an EVS worker. So those are the tensions that we deal with.
Thanks, Susan. And Jason is a little different, so let's talk about...
I was just getting all warmed up for what they said, but that's fine. Let's mix it up.
Same question, but I think highlighting the differences of Duke Regional with the two systems who are different that you've just heard from.
Yeah, so again, Jason Carter, president at Duke Regional Hospital. Duke Regional is about a 400-bed community hospital that's part of the Duke University health system, but we're also a county-owned and leased entity by the health system. So Duke Regional Hospital has been in existence for 50 years this year. October 3rd, we'll celebrate our 50 years, and it began in Durham by combining the white hospital and the black hospital. So at our root and our fabric in our community was bringing two separate race-based delivery models together to serve the residents of Durham and Durham County. So very interesting. So we think about being a very complex, busy tertiary center, no more than 5 miles down the road from Duke University Hospital and the Quaternary Academic Center. So very connected in that regard, but still by its founding and some of our delivery, a very different mechanism. Through that as well, and our agreement with the county, we are also the primary funding source, direct and in-kind contributions to Lincoln Community Health Center, which is a federally qualified healthcare center that services our community. So the populations we serve in Durham, people ask me all the time, how are your patients different than Duke University Hospital? They're not, outside of acuity and other mechanisms in that regard. And so our mission is very similar, very aligned with the health system side. But again, we're meeting different needs in our community through those mechanisms and through those models of care. I am not a physician. I want to qualify that real quick. I'll share with you, though, my background. I always wanted to be one. You may not know by looking at me, but I grew up in a very humble beginning with not a lot of financial or other resources around me. I wanted to be a doctor. but did not pursue it because I didn't think I was smart enough, didn't have the support to do it, and thought it was socioeconomically impossible. How do I afford it? I needed to get to work. So my love for this work has always been there, and I think it's carried me to do what I do today. And if anything, my own personal story around a career path, I think in many regards, translates to those that are accessing healthcare in general. I think many times those barriers and the tensions we have are far more perceived than real. And I think that's part of kind of our role to do this. Now, saying that, as we think about the tensions and the way that we serve, let me say something that's not overly profound. This work is hard, right? So we continue to see significant pressures coming our way. We continue to see reductions in those insured. We see reductions in the way that we're paid for those that are. But the reality is, even in the face of the current environment, executive orders and bills, it's not much different than what we've encountered before. We could go back to 1997 and the Balanced Budget Act. We could look at 2010 with Affordable Care Act. Each of those times were significant shifts in how patients were coming to see us and how we were being reimbursed. So the reality is, I think one of the biggest tensions we have is we continue to see movement and change in a dynamic to the model by which healthcare is reimbursed. We see increases in the cost that it takes to deliver it. And the unfortunate reality in many circumstances, in times where things are getting harder, when we should be innovating and investing or prioritizing mission, we all come back into our shells in this cost-minded methodology. I think I've heard so many times in my career from people like me that say things like, we can't cost-cut our way to prosperity. But in reality, that's almost always what we do. We think about it, and we get very myopic. So I think some of the challenges we have and what we have to think about when we move forward is times like these should not change mission. In fact, what it should tell us is if our missions are true. We talk about margin, we talk about mission, and too many times they're mutually exclusive things. And I think that's the problem. I think the challenges we face and the tensions we face is that mission should not be conditional. So we think about investing in social responsibility, access, equity, those things that we know inherently are important, but we do that many times conditionally when the economic conditions or payer mix allows. Now we have to balance that. We have to be mindful about it. But I can tell you in the case of Duke Regional Hospital, even over the past 2.5 years that I've been with the hospital, we have continued to look for ways to actually spend more money to affect the system of care in a positive way. So one quick example, and I'll stop talking on this question. In our hospital this past year, so in our hospital, which may not be different than a lot, about 400 beds, any given day we have 30 long length of stay patients that are there for many reasons that at the present we're not doing anything to support them. So can't get to long-term care, social, behavioral reasons, etc. So significant strain on cost as well as the delivery of care. So we do a lot of work in immersion weeks to turn the keys and the table over to our staff to say, how would we fix this? We had a provider group and staff come forward and say, these patients would probably do better if they got outside. So we launched Project Sunshine, and we took those patients outside on a regular basis with conditions allowed. As a result of that, what did we see? Reduction in delirium days, reduction in workplace violence, reduction in BERT or behavioral emergency response team calls. As a result of improved behavior of the patients, the conditions that didn't allow them to be placed in long-term care went away, so our length of stay reduced with it. So here's something that's totally different out of the box. And so what are we doing now? We're investing about $300,000 to create a team of NAs that do nothing but take people outside. So again, things that seem simple and cost prohibitive, we've got to, I think the tension is understanding the realities of pressures, but knowing that we've got to be investing more. So in these periods of time when it's challenging, instead of running to our shell, I think we should be running and looking for ways to continue to invest in the system of care and stop living in this duality of margin and mission, and instead looking at it as a singular focus.
Thank you. I'm going to tee off that a little bit because it's interesting. I was asked a couple weeks ago by Modern Healthcare. They're doing a story on all the things that hospitals are doing to cut their way to get ready for, I won't call it beautiful. HR1 and the pressures that it puts on us, particularly as you keep hearing, I mean, the payer mix across the board for the four of us is pretty significant with the government, which means you're not just interpreting government regulations and lobbying and doing all those other kinds of things, but you're dealing with some unrealistic expectations because they're setting prices. At the same time that we need as business leaders, including our physician business leaders, to invest in new things, new technologies, and or invest in a program like you're talking about. And so I'm curious if you could talk a little bit, and let's start with Susan, on we are businesses. We do have to make money, and we have to improve the quality of care. And what's your strategy as you move into the next couple of years where we're going to see more cuts coming from our government payers to invest in your system?
Yeah, so this is a very timely question. We are preparing for the HR1. I can't call it beautiful. I just can't. This is going to have a profound impact on our organization just because of our payer mix. So we just went through a very painful budget cutting exercise because we're going to lose about $300 million a year when these cuts really start in earnest. That's a big deal, especially when costs are going up at the same time, right? And in an organization like ours, more than 60% of our costs are salaries and benefits. And we don't even negotiate those salaries and benefits. The city and county does. So we have no control over that, basically. So what we have to do is work on the things that we can control. And that's kind of my mantra. We're a lean-based organization, which means that we're hyper-focused on the patients, the staff who are taking care of the patients, and, basically getting ideas from the front line about things to change. One example of that we implemented last year. For one of our infectious disease doctors says, hey, one of our primary admitting diagnoses is skin and soft tissue infections. And because of the patient population we take care of, we're often admitting people for skin and soft tissue infections when in another hospital that might happen. So the infectious disease physician who proposed this said, hey, there's now a long-acting antibiotic called dalbavancin. And what if, instead of admitting these patients, we provided that long-acting injection in the emergency department and then follow the patient up in another week or so in the clinic and see how that's going. And then we can admit them if we have to or see them, sooner. So that thing alone, even though dalbavancin is not a cheap drug, has saved us hundreds of hospital days. So we have 100 fewer beds than you do, but we have the same or more patients who are sitting in our hospital who don't need acute care. It's a profound problem that backs all the way up to the front door of the emergency department. And so anything that can reduce hospital days is a really important thing. So just basic, what ideas does the front line have? What ideas do we have about saving time, saving money, making things more efficient? We did a very extensive value mapping project at the front door of our emergency department. We have not only the only trauma center, but the busiest emergency department in the city. We're seeing more than 200 people a day now coming through our emergency department. It is really important that we're only seeing people who have emergent medical problems. And believe me, with our patient population, that's not often the case. So we were having a terrible problem with leave without being seen, patients waiting, and then leaving without being seen. Through a very intensive value mapping effort, rearranging the way we triage patients and referring them to urgent care or treating them and then, discharging them from the ED, we're able to get our leave without being seen rate down below our goal of 2%. And it's been down there for the past year. So these are basic things that we can do with the tools and technology we have. I can talk, I have a whole other piece about how we're using AI and the electronic health record to do more advanced things, but maybe we want to give other people a chance.
And I'd love to hear from Dr. Carr, because we've touched on it without raising our hands and patting ourselves on the back. Most of what you're hearing about is about social responsibility. It's improving the health of the communities that we serve and the patients that we serve. So, but you touched on AI, and I can't believe this is the first time, or maybe the second time we've heard AI today. Can you talk? AI is not the only technology that we need to invest in, but it clearly can reduce provider burnout, create more efficiency. So I'd love to hear from Dr. Carr about how Mount Sinai is thinking about that investment.
That's a nice tee-up. Thanks. I'll just echo, poverty is like the nastiest of the chronic diseases. It is the parent of all of them, and there's just it just ripples everywhere. So Sinai is actually very, very committed, and I say that knowing that there are probably folks that wish we were less committed to the idea of using artificial intelligence in a lot of different ways. Maybe I'll just start with the most offensive thing I said recently, which was, I was in two different meetings. One was a bunch of investment folks, and they were talking about what they, how they should invest in AI. And they wanted to know, is it using the clinical piece we should do? Is it the business and the back office piece? Which companies should we be buying, et cetera, et cetera, et cetera. And I wandered into a conversation where I sort of said, look, the clinical piece is the massive unlock. It's not that far. This is bad data, so don't take it to the bank. I know this is a room of academics, but there's real signal that urgent care visits have reduced substantially since the new version of ChatGPT came out, right? So if you wrote that paper and I'm falsely attributing it to you, please let me know, right? But does that feel credible? Because it feels totally credible to me. There's now a chat-based way to get some information that's even easier than, Google, which we've had for years. So if that's happening without us trying, there is no, good housekeeping seal of approval on whether or not the information that Chat or Claude or whoever is giving you, but people are using it as medical advice. On the one hand, we're democratizing medical advice and allowing people to take care of themselves. On the other hand, we don't actually know if they're taking good medical advice or not, because that is sort of just wild type. There's not anybody saying, Mount Sinai has said that we agree with this recommendation. So, to stop it all together, probably not right, but to just blindly follow and to let your partners down the street in Silicon Valley decide that they're just going to go around us and reinvent healthcare delivery is a scary concept, which is why I would say that we have leaned so aggressively in and said, we want to be the assurance lab. We want to help to make the rules. We want to partner with the tech industry. We don't think if we just stick our head in the sand, they're going to stop. So we would like to have, we do this, right? We take every year, lots and hundreds thousands of incredibly bright, but a little bit not street smart folks. And we teach them how to become docs and nurses and researchers, right? That's what we do. We're an academic health system. There is a very, very, very smart, but not so street smart entity called Chat and Claude and Perplexity running around. Why couldn't we bring it into our ecosystem and think of it as a new member of the team and try to regulate the way that it grows up so that we can sign at the bottom of the diploma, in 4 years or at the end of their residency and say, yeah, this is good healthcare. So nobody was offended in the room of investors who sort of said, so again, on the revenue cycle versus the clinical, which one do I buy now so that it's good for me, right? They were offended at a different meeting I was in where I talked about the fact that I think we're dangerously close, if we're not there already, by the way, to just accepting this quietly existing two-tiered system that we've had in this country for a while. By the way, we're the docs for 2 public hospitals as a part of the health and hospital system. These guys are both publics, right? Yeah, we're private, not-for-profit academic, not publics. I'm going to venture to say, I don't know their state laws, that those hospitals get paid in a different way from Medicaid than we do. Ever say it's
real different.
California's real different. In New York, the publics are reimbursed in a different way than we are, right? So the question you didn't ask me, which was what we're doing in response to HR1, the rational answer would be, we have a public hospital system. Why would I continue to take care of all these folks that have public insurance? I should move them to H&H, right? No.
operating at 110% of people.
Well, can't means I don't want to, was what my mom said growing up. So, this idea that, but that's not our strategy. Our plan is not to just move them all to H&H. We work in partnership with H&H. We know that this is our responsibility. The mission's critically important, but we're knocking on the door, the very dangerous door of, if someday, have me back next year, and if we're going broke, might I move more of them to H&H? Well, is it in the interest of the organization and the people that we serve to have the organization fail? No. Should I consider that? I should. Would it really get in the way of the mission that we deeply believe in? Yes. So the offensive thing is, I said, some governor in the next couple of years, some Secretary of Health is going to decide to give unlimited primary care to the Medicaid population, to chisel away at 60 or 70% of the routine stuff that Dr. Perplexity, Dr. Claude, Dr. Chat is going to be able to do really soon. It's going to happen. I don't know which date it's going to be, but it's going to happen. And we're all going to say, I cannot believe that you're going to allow them to experiment with this entity on poor folks. And I'm just saying, what's the counterfactual? Because the counterfactual is no care. At least that's the direction that we're going. I don't even remember what the question was.
All right. I don't want to have an East and West Coast thing going on. Jason, could you opine on that a little bit? But I do want to transition because we do have a panel coming up of what I would call the next generation leaders. And we have many people in this room who I would say fit that bill. I mean, the typical hospital CEO is somewhere in their 60s, I would guess, on average. And so with all of the things that we've talked about, whether it's government, more reductions coming from the government. I was intrigued this morning because nobody talked about when does this great thing happen where we're going to change the world. But I'd love for you to opine on the business side investment, but then transition to the what do we need to do to bring up the next generation of leaders? And I know you're a youngster compared to at least me.
Thank you. No, it's a great question. And again, I think all of this, we have to look at it in a very interrelated way. And so one thing that I would just offer related to some of the challenges we face if we think about, and we are no different than anybody else. We're thinking about the impact of the bill. We're looking at the implication on top and bottom line. We're thinking about our models of care and shifting it all. I think one of our challenges that we've got to do a better job of moving forward, and it speaks a little bit to the type of leaders and thinkers we need. We do a very poor job of thinking in systems of care. And so if you think about that for a moment, it's the paradigm of healthcare. I mean, how are we organized by default in silos? Department, hospital, ambulatory, et cetera, et cetera. And so many times when we go to solutions, it often goes back or is slowed because we're spending a lot of work not necessarily thinking about the sharpest end of care and the people we're serving, but the constituents we have to manage internally the organization to get there. And I think the organizations that are going to be most successful, particularly in the face of the changes coming our way, are those that can really think in systems of care. One, it's because it's the way that we need to meet the needs of our patients, but also we've got to start making decisions and solving problems based on value propositions versus that kind of myopic approach to cost and revenue. Does that make sense? So really thinking about it from a standpoint of a lot of investments at the department level or the individual level they don't make a lot of sense, but if we look holistically at the problem, it meets those needs. And let's be honest, I truly believe, and I'll put this out here for you to think about, whether we're dealing with a fluent individual with great access and commercial insurance or somebody that's living below the poverty line with limited access, I believe regardless, we as consumers of healthcare, we're all looking for the three same things. First, don't hurt me, right? Do no harm. 2, know me. And 3, make it easy for me. So I think we can look at it through a lens of those things to really understand what people need and how we meet them at the sharpest point of care. We are in the business of meeting people where they are. So I think we've got to think about solutions in that regard. As far as how do we bring leaders up to maybe start thinking different and challenging those assumptions, one, I think the best leaders are willing to be the dumbest people in the room. That's easy for me today, considering all the smart people here and the things that we've heard. But what I mean by that, I say that somewhat casually, but we should be bringing people up that are creating environments where everyone is getting involved. So at Duke Regional Hospital, we talk regularly. And so our kind of acronym for leadership and our ethos is LEAD. Love your work, engage and empower, ask for help, deliver results. We believe LE&A has to happen to get to D, sustainable results as we move forward. So what are we looking for? We're looking for leaders. When we talk about loving our work, I could digress here for a minute and channel my Simon Sinek and talk about our why. We hear that a lot. But truly, I don't want to be dismissive of this. If we pause right now and took the time to go around this room and ask people why they do what they do, I hope we'd hear some very compelling stories. But we leave that early and often based on the challenges that we have. What do I want in leaders going forward? I want people that see this work as sacred and the people and communities we serve as sacred. I want people to be empaths and truly care for other people. It's going to be profound. We want people that can be engaged and we want to be empowered. Why did we lose so many people through COVID from leaving the profession? Because we didn't see a light at the end of the tunnel. Our fingerprints weren't on the work. We talk so often about engaging our workforce, but very few times where we really give them a level of control over it. So how can we bring leaders in that can truly bring people to the work? We're seeing tremendous improvements within our culture and our system of care through really a focused effort to give decision-making at the front lines and really listening. So again, hearing and moving through that, looking for solutions that are real solutions. I mean, often we're trying to solve problems in healthcare, and as leaders, the phenotype is, hey, show me that you can work harder for less. I think there's a few hospitalists in the room today. So the hospital's busy. So what do we do first thing in the morning? Hey, do me a favor and focus on discharges, right? We ought to then say water is also wet. But we just ask people to do more with less. We think about affordability. We look at primary care. Now we're trying to impart AI and other technologies to make it better. But again, there's a limited capacity. So how can we really get people involved in sustainable solutions? And then finally, we got to have people that can get work done, right? At the end of the day, we do have to deliver work and be unashamed about it. So again, I think that humble, truly humble empath that can bring people to the table and do a whole lot more listening than talking.
Right. Susan.
Yeah. I love what you said, Brendan, and I totally agree. Qualities that leaders need now and in the future, curiosity, humility, willingness to see, willingness to question, willingness to change. In our environment, for sure, perseverance, and self-discipline, meaning really being focused on data. And I want to use an example. I want to bring together the AI thing with one of our leaders who does this work so well. So younger cardiologist who runs something in our hospital called the Prospect Lab, which is using AI tools to try to make our patients' lives better. And 2 years ago, Luke Zier is his name, Dr. Zier and the Prospect Lab, and we, as supporters, won the Bernard Tyson Equity Award. This is given by the Joint Commission. This is a really big deal. So how did we get that? So Dr. Zier used the AI tools. I mean, they're not, in today's terms, they're not really AI tools, and I can talk about what we're doing now, but what he noticed is that we were really poorly performing in readmissions for all of our patients. And when he dug in and asked, why, asked why 5 times, why was that? Well, it was really being driven by the readmission rates of our Black African-American men who were being admitted for heart failure way more than the rest of the population. So we did a couple of things. One thing with clinical decision-making tools in the electronic health record, and then setting up a clinic for people with substance use disorder and heart failure. And that combination of those two interventions made us go from one of the worst performers in readmissions to one of the best, and we eliminated the disparity. right? So this is the kind of curiosity, and humility and problem solving focused on the patients that we need. Today, we're using large language models and using the data we have in the electronic medical record, which is so hard to access. I don't know if any of you work, I know many of you work in electronic health records. There's so much there, and it's so hard to understand what's really going on, right? But large language models and AI tools have the ability to bring the data that we need to the forefront. So using that in combination with our lean tools and value mapping tools, we're able to really understand at a detailed level what are the drivers that keep people in the hospital longer. So we can understand that, people are waiting for MRIs. People are waiting for physical therapy consults. What are the things they're waiting for so we can prioritize those? And not only do we know what they're waiting for, but we know how many days actually it adds to the typical hospital admission for whatever diagnosis we're talking about. So these tools can really help us a lot. And it's going to be our young leaders who have these qualities combined with the technical skills and abilities who are going to help us get there.
Thanks. And Dr. Carr, you've got the last word, and then we'll start taking some questions.
Well, so then I'll just piggyback on this last piece and say, we have gone out of network with two. Remember, we said we were going to at some point talk about the payers with two big payers, United and Anthem, two of our biggest. Going out of network with them is an incredibly complicated thing, administratively, logistically, and financially. And both times, and I'm happy to tell that story. It's long, but skipping past that, eventually we got back in network, and both times we reached out immediately afterwards and said, I wrote a paper with Renee Shaw, one of your lovely faculty members a long time ago, where we quoted Ice Cube and said, don't hate the player, hate the game, right? And I sort of called the insurance folks and said, that was terrible. I'm glad we passed that. We have a 3-year contract. In these 3 years, we have to figure out a better way because brinksmanship cannot be the solution. We sat down, we spent a half day with them. We sort of followed up, with a couple different working groups. And I'll say this about young folks and their fearlessness and their tech sophistication. At the end, because there's another thing I think that's beneath the surface here is we talk about whether it's the payers that are denying or the healthcare systems that are expensive or overutilizing. The intersection here, the employers and the patients do have a role. And I caught at the end of the last session that, this is not about patient blaming. This is about the fact that the employer essentially hires an insurance company to say no, right? The patient then comes to me, the doctor, and says, please say yes, get me more studies, right? And then I, either cave or don't cave. The promise is there, these meetings with the insurance companies and the young folks that are tech savvy and are rational and brilliant that I'm surrounded by every day. There is an envelope of reasonable care. And yeah, there's there's stuff on the one side and stuff on the other side that's either experimental, not ready to get paid for yet, not ready for prime time, and then stuff that's bad medicine. But there is an envelope. And if we can decide ahead of time how to land the plane in that envelope, and if we shake hands, the payer and the provider, the health system, we can reduce dramatically the administrative battling that we do back and forth on both sides and allow that patient to have immediate claims adjudication, immediate payment, and reduced administrative burden. I struggle with the idea of value-based care. I've been in that space for decades. The branding is tough. What it really means is, can doctors do less? Can patients ask for less? Will insurance companies be the good guy here that was, thank goodness they said no? I know that's incredibly harsh. That's a hard battle to win. You have to get it's tons of change management, saying that this is the envelope in which we practice and it's covered and ahead of time, and allowing the sophistication of large language models to say, okay, yes, done. You were in bounds. That's fine. Is doable in the near term because of the technology that exists.
Thank you. We have a lineup, please.
You can use my verification now. You see, so this is a line policy for you all. I think large language models are accessible to patients. They're accessible to physicians directly, and they're obviously accessible to hospitals. What are you doing to make it easier for physicians to bring their own large language models, patients to bring their own large language models in, for instance, the decision support situation where they need access to those health records that you control and they don't readily have access to.
All right, Brendan, go ahead.
I'm happy to swing, but I feel bad that I was just talking. You know, this is tell me if I'm getting this right, but a question here is whether or not that large language model should live inside of our data ecosystem and be walled off from the world to ensure privacy. Is that part of the question?
That's the opposite of what I'm saying. It's that physicians, through peer review, for instance, instead of have the ability to choose and implement large language models. Patients certainly do. We have 5 major vendors like ChatGPT Health and 4 others, Microsoft, offering health-labeled large language models as long as you have your health records available to put into them. And the biggest barrier that I see is convenient access to what's in the EHR.
So maybe I anchor on the fact that you introduced yourself and said patient privacy.
Yeah.
So unless we believe that those tech companies are going to treat your information the way that I'm going to treat your information, we're very far away from where you want us to be in getting there. And which is why I started where I started, which is we brought it into our ecosystem, the large language models. You're right, though. It's on our side. It's not allowing someone to bring their agentic model to interface with our systems or our agentic model. That is going to require trust with the tech community. And I'm not sure that healthcare has a whole lot of that right now.
Go ahead, next.
Yeah. Hi, I'm Emily Cleveland-Manchanda. I'm an emergency physician at Boston Medical Center and the director for social justice education at the American Medical Association. My question is actually a bit quite different from the AI one. I really appreciate how each of your hospitals are doing work to ensure frontline input into solutions. That makes a tremendous amount of sense to me. And as an emergency physician, Brendan and I get to see how our system is failing people every single shift. And so I'm curious, and this has come up in a couple of different ways, how you're bringing patients into those solutions. I spent a month as an inpatient before my last kid was born, and a bunch of time in the hospital with other kids who are complicated. And my experience as a patient has really shaped how I think about solving problems. As we redesign systems with frontline interests, our systems are so incredibly provider-centric. It's convenient to do rounds at exact same times. It's convenient to have mother and baby units split, right? Like, how do we actually think about solutions that would simplify our systems and break down silos while also keeping the patient's actual experience at the center?
Would love to answer this question. So thank you for mentioning that. I think in general, we don't do a good enough job involving patients and direct patient feedback in what we do or the changes we want to make. So I mentioned before that we did this whole process redesign of the triage area of our ED, which is the busiest part of our ED on most days. And so through the brilliance of the people who were running that improvement effort, we used our NRC data from patients to actually get feedback on the changes we were making, because you can text message them right after the visit. So we could survey them about how they like those changes, as well as surveying their general satisfaction with their ED visits over time. And so that was the best way I've seen so far of incorporating patient feedback. The other thing we could do is ask them in those surveys, do you want to be more involved in decision making? So we could identify people who wanted to spend more time giving us feedback. And so I think using that, as well as the feedback from frontline staff, which is much easier to get, I think that was one of the reasons why our intervention was so successful and has been durable over time, because of that really direct patient voice involvement.
Yeah, no, and I think it's critical. And one thing that I'll say too, I mean, the emergency department, I'm a big fan of the ED. I started my career in emergency medicine running emergency departments. And honestly, I'm not surprised that we often see emergency medicine trained physicians in leadership positions. I think it really does provide a very unique lens to what's happening, not just in the hospital, but in the healthcare community. And so we work really hard. One, our relationship with and through our providers is paramount. And so one of the things that helped to establish with our CMO, Brian Burrows, who's in the back of the room, also an emergency medicine physician, is a very specific physician advisory council where we meet with core physicians every month around the hospital to spend time hearing exactly some of that feedback. And again, I know that's not necessarily voice of the patient, but hearing from providers and empowering them around solutions, or if anything, helping to keep me and us as a senior leadership team closer to what can be a month-to-month dynamic in what we're seeing and how things are shifting. In addition to that, and I think similarly speaking, we are trialing right now, just got finished with a trial in the past 30 days or so of real-time feedback systems with our patients. So instead of letting them leave the hospital or turning it into a grievance, we leverage virtual nursing within the Duke University Health System, leveraging those individuals that are beaming into rooms and asking real-time questions on day of discharge, and then again, every 24 hours, asking what's happened, where did you have concerns, how could we help? One, from a hospital performance side, we saw close to a 20+% increase. I'm looking at Brian, seeing his head shake for me, in just satisfaction scores alone. But we also found mechanisms and opportunities through that to fix issues, including in clinical care delivery during that episode of care. Maybe most importantly, that we really loved through that, and we polled like 100 patients, generated 44 unique tickets. 22 of them was just patients wanting to share their thanks and praise for excellent work from our providers and staff. So again, that mechanism and loop, it's not just fluffy. It's encouraging, it's empowering, it generates more of that dialogue. So the more that we can, maybe further to your question, find mechanisms for that real-time feedback, I think it's a game changer.
Yeah, and I think many of us have patients who are either on advisory board, patient advisory board, patient and family advisory boards. And for those of us who are FQs as well, that's a HRSA requirement that more than 50% be patients. And they weigh in on things like the size of the print on the ID card, to the availability of language interpreters, to patient flow issues. So go ahead.
Well, thank you guys very much for coming. My name's Haley Simpson. I'm an oncologist at UNC Chapel Hill, so don't worry about the Duke thing. I'm not a basketball fan anyway.
She and I are going to talk a little bit afterwards. It's a whole North Carolina thing. We'll get into it later, please.
What you say a lot, Jason, resonates with me because that is one of our core pillars of medical ethics, which is to say justice of delivering high quality, equitable care to our patient population. And I think what UNC and Duke have in common is that we both embody that mission and try to deliver the highest quality care to the patients of North Carolina. And you all also reflected that, delivering that quality care to your health systems as well. So I appreciate you taking the time to share that with us. I'm learning a lot from this talk as someone who prescribes some of the most expensive possible therapies for our patients. My specialty is CAR T-cell therapy. There are patients who cannot get this treatment. It is currently the only cure for some people's cancer, and they can go on to live the rest of their life decades after getting this treatment. So when you talk about investing in your healthcare systems, I think this is an incredibly important thing, that we're not just talking about giving low-cost care to everyone, which is extremely important, but there is also this role for high-cost care and delivering it in the best possible way. So thank you for commenting on that. My question is actually kind of unrelated to all of this. I was just curious, in your roles as CEOs, to what degree do you experience the litigious aspect of medicine? Because that's something we're trained up. Oh, you should get another CT scan just because you don't want to miss something, that's a CYA. Is that a realistic fear that we have as physicians? Or, because that is something that's, at least on the provider end, probably driving up healthcare costs. And I'm just curious what you all's real life experience is with that.
Yes. And I'll defer to these two that could probably answer far better than I. I think that aversion to risk, we see that variability in practice. And I think that's why it's important everything that we do, that investment, managing this, we've got to think in the terms of the standard of care, right? And I think the more that we talk about standard of care and get formats together for physicians to interact, share data transparently. I mean, I think if you look at practice patterns and ordering patterns, et cetera, we need to build teams where we can be transparent about that, and not, apply appreciative inquiry to the work we're doing. I think many times I see providers very anxious around that for fear of, now short of, illegal, immoral, abusive, et cetera, how do we create an environment where we come alongside, really seek to understand, and then provide and communicate and build a relationship around the support for that? But short answer, yes, I think we do definitely see variability in practice for the wrong reasons instead of that standard of care.
Many of our physicians.
Our environment is just really different for a lot of reasons. One is because of our patient population. I think we have fewer lawsuits. We definitely still have them. And when we do have them, they're really complicated because on our site, we have about 7,000 people working on our site. Half of them are employed by the city and county of San Francisco, the other half by UCSF. So all of these, any lawsuit that comes has to be sorted out between those parties. So it's complicated, but I think in general, it's less of a pressure in a place like ours, and for a very sad reason. It's because our patients don't feel empowered enough, I think, to sue or take that on.
I was going to say the same thing. So the public hospitals where our faculty work, there's a very different mindset, and I think about it in the context of some of the things that we prioritize when we're talking about doing more with limited resources for the common good. And specifically, I'm talking about under overutilization, inappropriate, avoidable care, all that language. It is way easier to not order additional things and people that are disempowered and are not going to come at you than it is people that are incredibly well educated, incredibly entitled, have private insurance, believe that because their insurance is so costly that they should get that test, even if your instincts tell you, or the data tells you, or the algorithm or the envelope that I was just describing about what's covered tells you it's not a necessary test, right? Which again, right? So I said earlier, if we pretend we don't have a two-tiered health system, we're pretending, right? And so now what I kind of just said was, if you're not in that envelope, can you pay cash for that CAT scan that you don't need? Well, I work in New York, and the answer is yes, you can. Not typically through academic medical centers, but it is very easy to find a mechanism by which you're going to get whatever testing you want, whatever testing TikTok tells you need.
All right, I think one more question. Would you like to go? Did you get to ask? I think you asked a question earlier. Have you been up? Is that okay?
Hi, everyone. Julie Rasalam. I am a health services researcher in training at the University of Colorado. And I had a question that was more about community power and people power. I would love to know what role community-based organizations and communities play in affordability and sustainability for your hospital systems.
Great. We have a minute and a half. Who wants to take it?
Community is extremely important where I am. And it's about, we have in San Francisco, we're very small. We're 7 by 7, very small, dense community where there are a lot of very active interest groups, patient groups, unions. The politics in San Francisco was famously once described as a knife fight in a phone booth. And so that politics extends to our advocacy groups. And so there is a lot of advocacy about care from a variety of groups. I will say, though, that what they're always asking for is more. The unions want, more jobs, higher wages, better benefits. The patient advocacy groups want more services, inside and outside the hospital. So in our community, I would say the role of these numerous advocacy groups is just wanting more.
Great. Thank you. I think we can try and squeeze it in 20 seconds. How's that? Or at least frame your question and we'll be out soon.
Okay, I was going to say, I'll just frame it very quickly then. Like I said, I already introduced myself, so I won't waste the time on that. Speaking kind of collectively with all the questions really fed well into what I want to ask, which is specifically, long story short, we have had a very hard time in a medical debt project I've been spearheading for about 4 years, getting hospitals to the table specifically with patients and giving that information about medical debt and really having an active conversation about policy solutions. So given your high ranking with the Lown Institute findings, I was just curious if you have any suggestions specifically, because usually what we hear is you have to sue the hospitals to get them to the table regularly because they just don't want to talk about medical debt or extreme collection actions. That's what we've heard from some other advocacy groups, and we're at a foundation. So we have some relationships, but we have a really hard time. We can talk to patients or we can talk to hospitals. We would love to get them both to the table to a more productive conversation. So just if you have any tips or advice on that.
Well, it might be something on Lown we consider ranking hospitals on their willingness to have those conversations. I don't know. He's got his hand on his head. Anybody on the panel?
I mean, I guess I would just say, it's an interesting thing to bring to a hospital association. That might not be where you think you go, but these are we have a lot of conversations behind closed doors, and talking about what the rules of the road might be in that relatively safe environment, and finding out how variable we all are. I don't actually know the rules around that for my peer health systems in town, but I can influence them. I see them and talk with them about other things, and I think we're pretty good on this issue. But I might be wrong. So, a little bit of fresh air, a little bit of sunlight, not a bad idea.
Absolutely. All right, please join me in thanking these three individuals